Good morning, everyone, and welcome to the Public Safety Solutions for Substance Use Disorder ECHO. My name is Julio Sotorblanco, and I will be the facilitator for today's session. This ECHO is brought to you by the Center for Substance Use Training and Telementoring, also known as CSAT, by Be Well, Texas, in collaboration with the UT Health San Antonio ECHO program. A few housekeeping items before we begin. We have live closed captioning available for today's session. If you would like to view closed captioning for this session, please navigate to the bottom of your Zoom window and select the Show Captions option. If you're having trouble accessing captions or having connection issues, please chat Echo IT Cato for assistance. To help us with attendance, enter your full name, affiliation, and email into the chat. Please remember to stay muted unless you are speaking. We encourage you joining by video and using the chat and/or raise your hand feature to post questions or share perspectives throughout the session. As a reminder, these sessions are being recorded and will be shared on our website to ensure privacy. No personal health information is allowed at any point during the session. This includes client and patient names, addresses, birthdays, or any other identifiable information. At the end of the session, the ECHO team will send out a post-session survey link. We kindly ask you to complete it as it provides feedback on how to refine these sessions to better address your priorities. We're approved for CEs for paramedics and any public safety professionals with a behavioral health degree, such as social work or counseling credentials. Finally, ECHO is an all-teach, all-learn environment, and we do encourage everyone to participate in the conversation and raise questions. With that, I'd like to move on to some introductions. So starting with our hub, we have Dr. David Miramontes.
Hello, my name is Dr. Dave Miramontes. I'm the medical director for the San Antonio Fire and EMS Department, and we do a lot of work in this OUD space, including buprenorphine and referral, as well as overdose management.
Thanks so much. We also have with us Jeremiah Golka.
Hi, everybody. I'm Jeremiah. I'm with the Shield Training Initiative. We provide occupational health and safety-oriented trainings to people across the public safety space to help improve their effectiveness in responding to drug-related encounters that will be win-win, make everything better for the personnel and for the people they're encountering for better downstream results.
And we also have Cynthia Mendiola.
Good morning, everyone. Thank you for being here in the session. My name is Cynthia Mendiola. I am retired from the federal system as a probation officer. My specialty was substance use disorders and mental health. And I'm also a trainer and coach for core correctional interventions. Happy to be here.
Thank you so much. And today we do have a really great treat. We have Dr. Margie Balfour. I hope I'm saying that correctly, and Sergeant Jason Winsky here as our didactic and case presenters for today.
Are we doing
intro too? Yeah.
So hi, I'm Margie Balfour. I am a psychiatrist based in Tucson, Arizona. I work part-time for Connections Health Solutions, which operates crisis centers in Tucson and multiple other states. And also I'm on faculty at the University of Arizona and am doing consulting as well.
And hi, everybody. I'm Jason Winsky. I'm a sergeant with the Tucson, Arizona Police Department, where I've been for 20 years. I started with a lot of help, our department's mental health team, and I'm still there now. About 10 years ago, we work with vulnerable populations every day, operating a diversion and deflection model, which you're going to hear more about in a second.
Thank you all, and thank you all so much for being here today. Let's go ahead and get started with our didactic presentation. Cato, if you can bring up their slides. Y'all are free to take it away after that.
All right. Well, good morning, everyone. Like I said, my name is Jason Winsky, and I'm with the Tucson, Arizona Police Department. We can go ahead and go to the next slide. Does someone from Be Well want to do the disclosure? Or I guess I can.
Yeah, we don't have any conflicts.
That there. We don't have any, no conflicts to disclose. Yeah, next slide. So a few learning objectives for today. We're going to talk about ways to lower barriers to care within the no wrong door model of care. And we're going to try to highlight for you as best we can also a lot of our efforts in the substance use disorder population as well. We're very lucky in Tucson and in Pima County that we don't have to separate those populations very often when we're trying to connect people with services, which both Margie and I will talk about a little bit later in the presentation. And then Margie in particular is going to highlight some of our co-responder efforts, both within the Tucson Police Department and then with Connections Health Solutions with the embedded clinicians that we have. So those will be our learning objectives for the next, I think we have about 25, 30 minutes, Margie. So we're gonna try to get all that done. So very, very quickly, a little bit about kind of setting the stage for who we are and where we are. We are in Southern Arizona. We are about a mile from the international border with Mexico. We have about 750 police officers serving a city population of 550,000, but Metro Tucson meaning kind of spilling over into the counties, about 1 million people. Pima County is a huge landmass population, but almost all of the population is centered right just around Metro Tucson, Arizona. Like I said, we've had a dedicated mental health team for about 10 years now, and we have a crisis intervention training program, which might sound familiar to everyone, that's over 20 years old now. And I will just touch on it briefly. We are a Department of Justice learning site here. So if anything in this presentation, catches your ear or your eye and you want to come learn more, there is some limited funding available to come visit Tucson, just not in June, July, or August. You just cannot come here during those months because it'll be about 113 degrees. Next slide. So a little bit about the foundation of our programs here. A lot of it starts with training. So I mentioned crisis intervention training. About 50% of our police department is trained in CIT. 100% of our police department is certified in mental health first aid. And then we have a variety of advanced training options. We always want to mention that during this presentation because training has really helped us change culture in how our law enforcement officers think about mental health and substance use disorder and diversion and deflection programs. And it's a big part of why we've been successful here. Next slide. So I'm going to touch on substance use disorder here quite a bit because I know it's a theme of this session. A little bit about how our mental health team works inside the police department. It kind of branches off into two sectors. There's officers that we have on the team. I'm the sergeant. There's officers that go out into the community and they're dealing with vulnerable populations every day. And it's important to note here that we don't delineate between substance use disorder, unsheltered populations, mental health populations. Obviously, we know that in some cases, someone might be experiencing all three of those things all at once. We are very lucky in Tucson as a police department because we don't have to interact or de-escalate someone thinking about in our minds, okay, which bucket does this person belong into? Okay, this person clearly appears to me anyway to be on a substance right now, intoxicated from some kind of substance. So what are my options there? I can go here or here, but I can't go here. Or this person's actively experiencing psychosis, some kind of delusion or hallucination. Okay, so what does that mean? What bucket is that person in? Where am I going to take them? Here, here, or there? We're very lucky because we have what's called a crisis response center here in Tucson, which Margie's going to talk about a whole bunch here in just a few minutes. We have a no wrong door policy. So unlike many other places around the country, it doesn't really matter why the person's in trouble, right? Why they're in crisis. We can scoop that person up. Ideally, they'll be voluntary and they'll be seeking help, but we do have an involuntary mechanism in Tucson as well, or in Arizona, globally as well. And we can scoop that person up and take them to the crisis response center. On the other side of the house, we have detectives. So I have two embedded detectives that work inside the mental health team, and they kind of focus on what you might all know as like the wraparound piece, the follow-up piece. So high utilizers of our 911 system, people who are being booked into the jail frequently. A lot of these people are of this bucket on this side of our house are experiencing substance use disorder, co-occurring diagnosis, right? Along with some mental health issues. We try to navigate those people into all different kinds of services, wraparound services, whole person care. And Margie's going to talk a little bit about that as well. And then embedded with our detectives and with our team as a whole, we have social work clinician co-responders that help us triage cases, help us offer people services, navigate people to services. That's very helpful. We'll talk about that later in the presentation as well. Next slide. All right, I think this is where I hand it over to Margie.
Yep. And so as the mental health side, so Jason just told you all of the wonderful, programs that Tucson Police has. And it really is, I just love working with them because they have such a nuanced and sophisticated understanding and approach towards people with mental health and substance use needs. And so our responsibility then as the behavioral health providers is to make it easy for them to do the right thing. So, and that means having a crisis system that's ready to receive the people that they're interacting with. And so, as you know, in most communities in America, we've sort of have this bifurcated system, which really is one of the, I think, biggest disparities in all of healthcare, where if you have a medical issue, you call 911, you get an ambulance, they're all trained in how to take care of you. They have places to take you. They're all set up to, do whatever it is that you need, versus mental health issues or substance use issues, and you get law enforcement. So SAMHSA has laid out, I guess it's been going on now for 5 or 6 years now, their vision for a comparable system for behavioral health, where everyone has someone to contact, which is the 988 line, then someone to respond instead of police, which is mobile crisis, and then safe place for help, which is specialized facilities. Next slide. So what that looks like in Arizona, for a variety of reasons, has been at this for a very long time. We had a lawsuit in the 80s that led to how we structured our Medicaid and our funding. And just over the years, the state has continued to invest in crisis services. And so we have a system that's actually, a lot of people come from around the country to look at the Arizona system because it is evolved into this complex, pretty comprehensive, coordinated system of crisis care. And um, and it's all aligned towards these common goals of keeping people out of jails and emergency rooms and hospitals. And, people ask, well, why, did this weird red state out, in Arizona? Well, I guess we're purple now, but, why in Arizona has there been so much investment in crisis services? And it's a lot of it is because the financial goals and the clinical goals are closely aligned. So what I want as a clinician is I want my patients not in jails and ERs and hospitals if they don't need to be. And if you're paying for stuff, you want those same things. So whether you're talking about responsible stewardship of taxpayer funds or clinical care or social justice, you're all sort of working towards those same goals. And so if you organize that into a system, you can think about the services on this continuum of the least restrictive, what we want clinically, the people in the community as much as possible, which also tend to be the least costly. So on one end, you've got, the easiest thing to do is to pick up the phone and ask for help. And so that's where we have our crisis line, which preceded 988. Now 988 points to it. They get about 6,000 calls a month from people in Pima County, and they're able to resolve, actually, these are real numbers, but um, they're a few years old. It's actually more than that now. It's like closer to 90% that they're able to resolve those on the phone. And they can do that through telephonic counseling, through connecting people to resources, whether it's mental health or substance use. And then, and they even have the ability to make people appointments in the system. From the clinics are required to have some crisis appointments available. And then if they can't resolve the crisis, then there's mobile crisis. And there are about 16 teams, I think, that cover Pima County at, different numbers of them at different times of the day. These are clinician only teams. So these are not co-responder teams. These teams aren't. They are either two clinicians or a clinician and a peer, and it's couple different agencies run them, but they're all essentially dispatched by the crisis line, so they can dispatch the closest person. And when they do their interventions in the field, they're able to resolve about 70% of those. And then for those who need a still higher level of care, we have our crisis facilities, which I'll talk about in more detail. And these are places where mobile crisis can drop off, people can walk in, emergency rooms can transfer to, and police can drop off at. And people who go there, most of them, the vast majority of them, were able to get stabilized and then discharged back out to somewhere in community-based care. And a crisis doesn't just flip off just like a light switch. There's the post-crisis care component is very important too. There are some programs that can wrap around, like a peer run program that helps get people connected. There are some lower acuity, like crisis residential type places where we can step people down to. And then, because one of our goals is also keeping people out of the justice system if they don't need, to be there, then at every point along here, the system is designed to have easy access for law enforcement or the public safety system. So the crisis line has staff that are physically embedded in the 911 communication center. And so they're there shoulder to shoulder with the other call takers. They're plugged into both the CAD system for 911 and their own system where they dispatch mobile crisis. And I think they intercept around 1,000 calls a month. And then they're able to have those shunt completely through this clinical pathway. And about half the calls they get, they're able to not have to dispatch anybody. And then, most of the ones they do they send mobile crisis to. There's things baked into, like, everyone has these common goals. So there's things like baked into the mobile crisis contracts to incentivize um, helping law enforcement. So for example, if I'm at my house and I call the crisis line and they want to send mobile crisis to me, their contract says they, on average, have to get to me within an hour. But if Jason's in the field and, like, he's at someone's house, they won't open the door, instead of calling the SWAT team as a barricaded person, they can call mobile crisis to come help them. And their contract says they have half that time, so they have a half hour to respond to um, the police. So there's these incentives are kind of baked into how the system is structured. And then the crisis centers facilities are designed to make it easier for law enforcement to drop people off rather than take people to jail. So 5 to 10 minutes and never refusing a law enforcement drop off. And so all of these decisions and how the system's organized then all converge towards those common goals. Next slide. And the facility part is kind of the most complex, like, because everyone now, lots of communities are working on building facilities, and that's kind of the hardest, most expensive thing to do. And for the longest time, one of the things that made it challenging is if you say the word crisis stabilization unit to like 10 different people in 10 different states, you probably get 15 different answers of what that means. And that makes it very hard to fund, to plan for, to design around, and for the community to understand like what role it's going to play. And so for this reason, SAMHSA earlier last year put out for the first time some definitions for what all these different facilities are. And we're going to focus on the green ones, which are in the category of low or no barrier. And that really is that no wrong door. Meaning, when I was part of the group that helped create these definitions, and one of the early drafts had had referral criteria. And like, if you talk to people who work in an emergency room and you say, like, what are your referral criteria? They look at you like you have two heads and they're like, whatever, we get who we get. And so, as opposed to a lot of behavioral health, which is, we have sort of a reputation in behavioral health of being difficult to access. You've got to send some packet over, and then someone looks at the packet and then like looks at their criteria. Then they decide whether or not you can bring the person there, or the person can come there. That there's a place for that, but for officers who are in the field with very high acuity people, it needs to be like an ER where they bring people there and then we get who we get and then the facility figures it out. So that's what the green ones are, and I'm going to focus on the dark green ones, which are for the highest acuity patients. So people who may be involuntary, agitated, violent, psychotic, often intoxicated. So these are people who oftentimes the more moderate acuity facilities will say, well, we can't take those people, so they have to go to the ER. So we're going to back the green ones. Next slide. And again, that whole no wrong door, that term gets used a lot. And so, it's really, we felt in the working on the SAMHSA definitions, it was really important to define what that means. And that's that no barrier. Emergency ready is another term that's used in those new guidelines. And it's that, you get who you get. And I don't know if you're familiar with the EMTALA law, but that's the law that emergency rooms, it's called the Emergency Medical Treatment and Active Labor Act. And, back in the day, you'd have someone who like didn't have insurance, and they would come like, in labor to the emergency room, and the ER would say, oh, no, you don't have insurance, go to the poor people hospital down the street. And so they passed this law that says you can't do that. That says, like, if someone lands on your doorstep, you have to take some responsibility, and you may end up ultimately sending them somewhere else, but you have to take responsibility and get them stabilized and assess them and then figure out what you're going to do. And so it's unclear if freestanding crisis facilities are covered by that, but that no wrong door kind of follows that spirit. Because we do get people sometimes who, do need some, additional medical stabilization, but we don't tell the officer to put them back in your car and take them there. We say, okay, yeah, we'll take them, we'll get them stabilized. And then, if they need to go to the emergency room, we'll handle that, and then we'll take them back. Next slide. And, for, like Jason said, we're fortunate in Arizona where we don't have to think about mental health and substance use separately, like in many places. And so I often have to remind myself when I'm saying mental health or behavioral health, I mean substance use too. And so all of the services really need to be capable of dealing with both. And this data from our crisis center in Tucson kind of underscores that. If you look at the what percentage of people come to our crisis center and say, I'm here for a substance use issue, or are brought, only about 15% say like, yeah, I'm here for substance use. But if you look at their diagnosis or our, toxicology results, it's like 2/3 have a substance use issue. And the majority of what we see is meth, followed by alcohol. And especially because we focus on that high acuity population, like people who are intoxicated on meth, those are the ones who are, really agitated in the moment, could be violent, you know, and those are the ones who really we want to have in a specialized crisis setting and not in an emergency room. Next slide. And again, this just talks about why it's important to be able to serve those high acuity people. So like your agitated meth patient, um, if your crisis facility can't take them, then they're going to go to jail, which I think we're all here because we agree we don't want to do that. Or the emergency room, which is not a great place. There's most ERs don't have any psychiatric services available. They can spend days or boarding waiting to be sent somewhere else. And then for especially for this population, the substance use population, they're more likely to be arrested. So you take them somewhere for treatment, and then they're not getting the treatment that they need in that environment, and then they assault someone, and then now you've got someone who's been assaulted, and then your patient got arrested and is in jail anyway. So that's why it's important to have a place that can take those people, where we have a specialized environment, we have specialized staff, and we could stabilize and treat these folks. Next slide. So one big key to making this work is that this whole issue of making it easier for officers to do the right thing and bring people to services. So Jason mentioned CIT earlier. If you go back and dig up like the original CIT manifesto, it talks about how CIT is not just the training, it's a whole community response. And a big piece of that community response is to have what they call a receiving facility. I highlighted these two things in the middle because those are the two kind of functions that are the hardest, I think, to do well, which is the no clinical barriers to care, which means you take care of everybody, and then the minimal police turnaround time. So our centers have a dedicated law enforcement entrance that allows people to, the officers to bring them in and out without having to go through and take their guns off and all that stuff they don't like to do. They don't have to bring people through the front lobby, in handcuffs and all that awkwardness. And we've got everything they need right there. So they're not having to walk around the facility, having our staff ask them about their guns. They can do their paperwork right there. There's a bathroom back there with a Keurig. We have donuts on National Donut Day. So they're able to get everything they need, right there. And then, we don't turn anyone away. So like I said, we don't require them to go to the emergency room ahead of time. If they do need to go to the ER, we can arrange that transport. The center in Tucson's right next to an emergency room. It's attached to it. But our other ones in other states are or not. So you don't necessarily have to have that. And we do this without using security guards, because our philosophy there is our staff gets tons and tons of training. So we would rather invest in more of our trained staff than default to someone who actually has less training. Next slide. As far as what happens, this is actually a picture of our facility in Seattle, but it looks very similar to the one in Tucson. Sort of the heart of the operation is, well, our 23-hour observation unit, which in the new SAMHSA language is High Intensity Behavioral Health Emergency Center. And this is an open area with recliner chairs. Why is it like that? Because if we're taking people who are psychotic, agitated, danger to self, danger to others, we need to have continuous observation of people. So that open area allows our staff to do that. But also too, like compared to like an emergency room where you're put in a room by yourself, they take all your stuff away from you and you sit there in isolation, waiting 12 hours to be sent somewhere else. That's not very therapeutic. We've known in behavioral health for, a long time, decades, that having that social interaction is therapeutic in and of itself. And then it also gives us the flexibility to accommodate surges in volume. So like if we had 16 beds in 16 separate rooms, if the police bring us the 17th person, we'd have to say, nope, we're full, versus this configuration is like more like an emergency room where we can flex up for surges and then, then back down. As far as what happens in here, our philosophy here is that we're going to assume that we're going to resolve your crisis. So it's not holding for sending people somewhere else. It's we start with, oh yeah, you need to be in this observation unit. We're going to work to resolve your crisis. So we have our psychiatrist or other providers 24/7 can start medication, start treatment. Our door-to-doctor times, one of our most important metrics, usually about an hour or less to get people started on treatment. We can do we can give psychiatric meds. We can do detox. We have a lot of people who are on detox protocols. We can start, medication assisted treatment like Suboxone, for example. And then we also have our peer supports who are circulating, who are doing groups, also doing one-on-one interaction. And then we're really working on figuring what's going on at home, what clinic resources do they have, what family supports, and figuring out what that person needs to be able to be stabilized in the community. And then at some point during that 23 hours, we reassess them, and many of them are improving, so we can get them back out to the community. And for the ones who are not, then we can keep them a little bit longer. And we're really trying to do that least restrictive. So least restrictive in terms of both getting them back out to the community, but also we get a lot of involuntary people, and we are also trying to get engaged with those folks, and even if they do have to stay longer, want to stay on a voluntary status. And so conversion to voluntary is another one of our metrics. Next slide. And then for those who need to stay longer, this is more of like a traditional unit with bed, individual rooms with beds, for people who need stabilization beyond that 24 hours. Having it all in one place makes it sort of a seamless episode of care, so you don't have all the inefficiencies of having to transfer them somewhere else and then having to redo a psych evaluation and redo everything. So that kind of helps make that more efficient. Next slide. Go back one. Sorry, one thing I just wanted to say, talking about in terms of substance use, what this level of care is really helpful for is, especially I mentioned our meth patients, and a lot of them come in and they're psychotic and paranoid and really agitated, and after 24 hours, they've had some sleep. We may have given them some medications to help them calm down. And they're better after 24 hours, but they're not, they're still disorganized. They still have some residual paranoia, or they're still just really, somnolent because they're crashing from the meth. And they don't really need to go to an inpatient psychiatric stay, but they need longer than that 24 hours. And so that's a great use for this extended stabilization, where they just really need a couple more days. And in the meantime, we can have our peers, trying to engage with them and trying to do some motivational interviewing, and, hopefully that they'll, be amenable to doing more substance use care afterwards. Next slide. And so putting this all together, Jason was mentioning our different co-responder teams. And, so over the years, because we've been working on this for so long, instead of, people talk about co-response a lot and co-responders, and we've kind of moved to more language around collaborative responses, because the more options you have, then the more you can tailor specific collaborations to a specific situation or specific patient need. And so kind of one way of organizing this is, we think about crisis, so we often are thinking about the orange part. That's the acute crisis where there's a discrete event that we need to have an intervention and it's high urgency. And ultimately, ideally, if there's not safety concerns, then that should completely be the responsibility of the behavioral health system. Like law enforcement shouldn't have to deal with that. And so that's where, that SAMHSA vision of someone to contact someone to respond a safe place for help, that system should be able to handle that. If there is a safety risk, then it's like, well, okay, how can we collaborate to get the person what they need? Sometimes the fastest and easiest thing to do is, on the phone, at the point of the 911 call, it's pretty obvious the person's going to need to be transported to the crisis facility. So, sending a CIT trained officer, is the best thing to do. There's other situations, kind of like I sort of mentioned before, like, the police have to, they got to report that someone's suicidal and they won't come out of their house, sending the mobile team to go assist the police for that. That's a collaboration that works for that. But we don't really have the co-responders like Batman and Robin riding in the car together to respond because we have our mobile crisis. And then, and then if they do need to work together, then they can, bring them on board. But then we also need to not forget about the blue part, because crisis doesn't just flip off like a light switch. It's really important as the crisis is resolving to make sure that we're getting people connected to the care they need, or else you'll end up with the cycle of a crisis again. Or as crisis is developing, there's opportunity sometimes to do outreach, to maybe get that person what they need before it escalates to the orange part. And so again, if there's not safety risks or criminal issues, then the behavioral health system ought to be responsible for that. In our system, there's some of that post-crisis wraparound. We call them second responders. Having case management after, people are coming out of crisis facilities, getting people into care is, quickly, having those crisis appointments available at the clinics, that all fits into there. And then when there is a safety risk or there is, criminal issues, that's where our co-responder teams fit. So Jason mentioned, like, he's got his dedicated mental health support team, and that team got developed in the aftermath of the Gabby Giffords shooting that happened in Tucson in 2011, where, it's like, how did you miss someone who was bumping up against the mental health system? Is there a way to keep someone from falling through the cracks earlier? And that's what that team was started for. And now we have, and so they focus on people who are high risk to public safety, multiple law enforcement interactions, or, people sending, threatening emails to the mayor, that kind of stuff. And then we have our case managers that go with that team and do kind of follow up, and they do investigations, and an investigation not for criminal reasons, but investigating, like, was this person connected to services and they fell off? Do they need to be connected to services? What does this person need? There's also a team that's dedicated for substance use. Started off as a grant-funded program that they continued afterwards because it was so successful. It's another agency in town that does a lot of opiate MAT, and they have a peer that goes with that specialty team that focuses on people who've overdosed and, had to be rescued with naloxone, or the Tucson Police has the ability to deflect and not arrest people for substance use. They'll follow up with that population and try to get them connected into care. And then there's other teams that do homeless outreach that sometimes have homeless recovery peers with them as well, that are going out in the parks and the encampments and things like that. So that's kind of how we've tried to organize things. Next slide. I know we're coming up on time, so just a bit about return on investment. So, this is some sort of back of the napkin analysis that was done a while back, looking at all these crisis services. And of course, the healthcare system is very focused on healthcare savings, right? So, you could look at savings in terms of ER and inpatient hospital use. But what's interesting, though, I thought about how they did this, was also looking at all that time saved from the officers. You can calculate that into like FTE saved. And so when you're advocating with your city governments, this is a really effective thing because pretty much all police agencies are understaffed. And so this is, the equivalent of putting some officers back on the street to do things that they should be focusing on and not all this behavioral health stuff. Next slide. And we did a research study. I'm not going to go through all the details of this, but we I'm a research nerd too, and we looked at the Medicaid claims, and we're able to kind of construct episodes of people going through the crisis system. Like you start in mobile crisis, you end in the crisis facility, for example. And basically, what this showed is that if you have a crisis system, people will use it. So over half, so 57% of these crisis episodes began with mobile crisis or going to a facility rather than go into the emergency room or a hospital. And then when we looked at people who went through our facility and whether they had to reutilize crisis services in the next 30 days, most of them did not. And those that did, the vast majority of them, when they did reutilize, they were reutilizing in the crisis system and not ERs and hospitals. Next slide. And relevant to this discussion is when we looked at things that predict that reutilization, things you might expect. So homelessness, stimulant use, especially. Everyone wants to talk about opiates, but meth drives crisis a lot. So those are populations I think that need, we struggle with that population too. So I think we all need better interventions for that population. Next slide. And just to finish is, we're blessed to have all these resources, but it didn't happen overnight. It's been a long journey, beginning with just setting up CIT and a mental health court. And then, over the years, you've seen its exponential increase in things. But, so wherever you are within your community, you're in the right place because you're on the trajectory. It takes a long time to do this work. Next slide. Or that's the end. So. So, yep, I think, happy to do questions, or I'm
Yeah.
not sure of the format.
Yeah, I think
but-
we'll pause for questions now. Is that right?
Yeah. So thank you so much for this great presentation, guys. It was really, really awesome. So I do want to take a moment and open up the floor to the Learning Network or our hub for any questions that they have for either Dr. Balfour or Sergeant Winsky about their presentation they did today. Cynthia, I see your hand raised. Go ahead.
Hi, my name is Cynthia Mendiola. This is amazing. I think that's the the missing piece I just put in my comment. But my question is, I know it sounds very involved and very comprehensive. What kind of advice would you give, other communities, other cities that they could, start on this? But what would be a starting point for them? And would it be with the police? Would it be with a mental health community? Because many tend to be working in silos. And so how would you suggest they would
I would
start?
kick that over to Margie for maybe the toolkit or the crisis roadmap.
Yeah. So, one thing I didn't have time to really go into here is that to have this system, like, all the different parts don't just like up and by themselves decide to work together. There has to be some kind of organizing. In this, I was part of a group that wrote this report called the Roadmap to the Ideal Crisis System, which I'll put in the chat when I'm done talking, which talks about this idea of an accountable entity that is kind of coordinating all of this. In some systems, it's kind of baked into how it's financed, which I think is a strength of the Arizona system. All the different funding streams, from Medicaid to like the block grants that counties and stuff get, all goes to a regional behavioral health authority that they can contract with all of us. And then that entity kind of brings in others like the police and first responders. Other communities, many communities, it's separate. And so in that case is you want to have it kind of depends on your community who's the right convener. In some places there may be like some kind of county behavioral health collaborative, and like building on that makes sense. Some communities it's like the CIT advisory group has sort of morphed into something like larger, but organizing, you want to get all the people at the table. And I think that's the first step. And, both in terms of who's out there doing the work, like your first responders, but also in terms of your payers. So in most places, there's a Medicaid system and it's sort of off by itself. And then there's, county or local behavioral health authorities, and they don't talk to each other. And having them together and coordinating, I think, is really important as well. But the roadmap to the ideal crisis system has kind of some self-assessment stuff in there that can kind of help, and it has advice for how to start getting your community together. And that report really influenced the updated SAMHSA guidelines. And so a lot of that information kind of made it in there as well. But I'll stick that in the chat.
Thanks so much. Jeremiah, I see that you have your hand raised. Go ahead.
Yeah, I'm happy to wait also if other folks in the community want to ask a question. My question was about sort of process when if an encounter happens that involves a regular like line officers and not specialist officers. So I'm sorry if you kind of already said this and I just didn't process it when you're explaining it, but kind of what is your process for when it's the line officers are having an encounter?
Yeah.
That's my first question.
So about half of our officers are trained in crisis intervention training. And if you're familiar with that, that's like the gold standard of law enforcement de-escalation training. And having half of your department trained in that means that 24/7, 365 people are working that have the certification that can come to that scene. And then 100% are trained in mental health first aid. So that's actually a really good point. Like we talk a lot about my team, which is a highly specialized, team with a lot of advanced training. But the bulk, right? The majority of our diversion and deflection efforts are right there out there with the line officer, taking people, scooping them up, taking them over to Margie, right? And getting them the treatment they need and diverting and deflecting them away from the jail.
Okay, cool. Then a related question, and I think you may have spoken to this, but I know when we talk to a lot of departments that time is a big issue, and so a lot of particularly like the untrained, a lot I know people who are not trained or kind of bought into this type of system among line officers, maybe like I don't have time, it's maybe it's a perception for, it's sort of a self-imposed perception, but I don't have time to spend time here. I don't, I've got all these calls are backing up. I can move on. But it sounds like you all have kind of a sort of a policy approach to that, to be building in time.
Yeah.
Like how do you deal with that?
So it's kind of an ironic question because the way that we, like Margie was saying a second ago, we got very lucky in Tucson because law enforcement got to be in on the ground floor all the way to the design phase of our crisis center with diversion and deflection here in Tucson. So the irony of your question is that in Tucson, and actually I think most places, especially post-COVID, right? That's the key, post-COVID. It's actually more effort, more time, and more paperwork to book someone than it is to deflect them. And if there's a community out there where that's not the case, well, then you need a quality improvement process with people way smarter than me, like Dr. Balfour, because something's totally wrong. Booking someone post-COVID in the United States of America and post-fentanyl can take hours. It could take 5 hours, 6 hours to book someone. If they get medically rejected from the jail and you have to take them to the hospital and then back to the jail, all of your diversion and deflection efforts should be faster than that. And then
And our
Margie, I
drop-off
know
time
Margie
at
and I are
CRC.
very passionate about this part.
Yeah,
So
it's
Margie, I
like
know you want to add on.
it's less than 5 minutes for the
Yeah.
officer at the CRC.
Cool. I feel like this is a message that we hear, the fast message among the folks who know it. And so it's like, I feel like this message needs to kind of get out more. That's great. That's cool. Thank you.
Great. Thank you so much. Cynthia, I know I see that you do have your hand raised. I'm going to move through announcements really fast. And then it's still going to be Sergeant Winsky and Dr. Balfour afterwards, so we can ask those any additional questions that anybody else has. All right, cool. So to claim your CEU credit, you must complete the post-session survey in the chat or by email sent after this session. Complete the post-session survey and select yes on the question, are you applying for CEU credit for today's ECHO session? Your certificate of completion will be sent to you 2 to 3 weeks after the session date. If you have any questions, email bewelltexas@utesca.edu. Even if you don't plan to claim CEUs, we encourage you to complete the survey. Your feedback is invaluable and helps us improve and tailor future sessions to better meet your needs. Next slide, please. The Center for Substance Use Training and Telementoring offers technical assistance for various substance use disorder needs and topics by our team of experts. To request technical assistance, please complete an online request form and we'll be pleased to help you. Next slide, please. Don't miss our final Texas session, Setting a Blueprint, a pilot to build recovery housing business sustainability, before we kick off the annual symposium. Please join us on Tuesday, February 24th at 12 p.m. Central Time. To register, visit the link in the chat. Next slide, please. And registrations are still open for the 2026 Texas Substance Use Symposium, Texas. Join us March 2nd and 3rd, 2026 at the Henry B. Gonzalez Convention Center here in San Antonio, Texas, for 2 days of learning, collaboration, and connection. To learn more, visit the link in the chat. And note, registration closes on Monday, February 16th. Next slide, please. And lastly, please join us for our next Public Safety Solutions for Substance Use Disorder Echo on Thursday, March 12th at 11 a.m. Central Time. With that, let's go ahead and walk through the case. Sergeant Winsky, Dr. Balfour, go ahead, take it away.
Hey, so we don't have a slide for this one, but we thought we could just have a discussion about it. So we had a case a couple of years ago that's really a good example of all of these systems coming together. We had an elderly lady, she's actually, I think, 87 years old. She was unsheltered, living in her car in a parking lot of a church. And the church was helping her out significantly. And eventually, over time, like she was just deteriorating and needed an inpatient stabilization. And the church very reluctantly ended up getting a petition for her because she was not in a state of mind where she could voluntarily just go for stabilization or go for services. The biggest problem is my team goes out there and we see this lady that really just needed a lot of help. And we've all of her life possessions, right, were inside the car. The car was filled to the ceiling, the roof of the ceiling of the car was just filled with basically her life's possessions. And to make matters worse, the car wouldn't run, right? The car wouldn't start. So we were sitting there thinking, oh my gosh, what are we going to do? We thought about all these different kinds of solutions to get this person stabilized, but not separate them from their property, because obviously separating them from their property was going to cause a lot of anxiety. Eventually, after several hours of trying to work on this problem, we found a tow company that would donate a tow to our police department, really is what they were doing, and to this person. And we were able to tow, for lack of a better term, her and the vehicle down to the crisis center for stabilization. And the relief for her was just immeasurable. Our co-responders were a big help in this one too. And then with a lot of help from Dr. Balfour, we were able to do another kind of special thing for her to kind of reduce her anxiety while being inpatient. We were able to give her a special room, and I'll let Margie pick it up there.
Yeah, so, and one thing that is really great about working with TPDs, I mean, they could have just brought her in. They had a judge's order, but they were doing all of this because in order, to not get her, have her be agitated and then have to, take her like, by force. They were doing all of this. And then, so that translates down to then, when we're then going to be receiving her, and we don't want to, we want to do everything to not elicit agitation, right? And so we knew that her being separated from her possessions is what was going to get her anxious and agitated. And then that could, lead to, having to give meds or go hands-on. And, we want to avoid that. And so we figured out, how to ask security a favor from security. Cause I'm like, can the police tow this non-functioning car to our parking lot and you not give it a ticket? And, so they agreed. And then we figured out, cause, she was going to be in our extended stabilization unit, and towed it to the side of the parking lot where from the windows on the OBS unit. And then if she went upstairs, the windows on one of the hallways, that she could actually see it in the parking lot. And so that also, she was able to check on it and know that, it wasn't going to be towed away, and that, we weren't just lying to her, that we were going to take care of her car. And that just really had an enormous, impact, and, really helped her clinically be able to participate and engage in treatment. And so I think it's just a great example of how, like I said, it's a collaborative response, and there's no protocol written that says we tow people's cars, but we just figured it out. And yeah.
Thank you all so much. At this time, I'd like to open up the floor for any questions that we have whatsoever. Feel free to unmute and ask your questions.
I know there were some hand raised before we did the case, so if you still had questions on the presentation, we're happy to take those too.
Well, my question was just reinforcing what you're doing. And I really thought that was good. You do the work up front, you work with the individual, have the patients, and then you really save a lot of work in the back end. And I wanted to support that comment. But the other thing that you were saying is that, sometimes those little things that aren't written in the policies or in your map, but you understand how it contributes to their mental health. And if people take the time for that, then you have a lot more success of participation in the program, which is awesome.
Thanks. Yeah, one thing I like to say about crisis is, there's no, you can't make a rule for everything, because, you think you've seen everything, and then like tomorrow happens and it's like, oh, I've never seen that before. And so, so I ran the CRC directly for, quite a few years, and we took it over because, from previous management, because it had been having some problems. And that was one of the things is, before they had been afraid of not breaking rules and getting in trouble. I mean, to the point of doing things that like don't make any sense. Like I remember once I was walking through and I heard, some commotion, and we have a youth unit as well, which we didn't talk about. And there was like this adolescent girl on the floor in handcuffs, like kind of banging her head against the side of the wall while the sheriff's deputies and our staff are standing around watching. And I'm like, what was going on here? And they're like, well, we haven't like gotten a hold of her parents to sign consent for treatment, so we can't touch her because that would be battery. And it's like, does that make any sense? And, okay, yeah, that may be, technically true, but, I don't think that reg was written in anticipation of this situation. And so one thing that we really tried hard, to instill in people is that, there can't be a rule for everything. So we have to really have everyone understand what our values are, and then empower people to make decisions in the moment based on those values, and that we will always back you up for in good faith doing the right thing. But we will not back you up for like standing around and not doing something that is obvious, that the person needs help. So you know, I think that's really important for people to sometimes get out of the weeds of, because there's a lot of gray area in crisis work. And, when there is that gray area that you just, you know, that's like, if you can remember nothing else, it's follow the golden rule. And like the prime directive is safety is the prime directive, do what's safe for the patient. And someone's talking with like, they're muted. I don't know if you're trying to talk. Oh, okay.
Dr. Miramontes, I'm going to flip on the other side. In a lot of communities, the trust of police departments has been waning, especially recently with our ICE detention concerns. So in our community, for example, we have co-responders, right? So it's a police, a clinician, and a paramedic. So all three areas are covered as far as safety, security, emergency detention. The social worker or the licensed clinical clinician works with that perspective, and then the paramedic works from the medical perspective and can give medications. So that's how we did it. But how would you respond to someone who said, whoa, wait a minute, cops going to mental health issues? I don't think I like that idea. It's part of this defund the police. And actually, our program got started with a criticism of our police because they were not managing mental health folks as well as they could, with CIT training and the other things. So these other co-response teams were started. So how do you respond to why
we get that question
doing this and not clinicians?
We get that question a lot, and we're very passionate about this topic as well, both Dr. Balfour and I. So I suspect we're both going to answer this one, but first and foremost, from the police lens, right? You could do a Venn diagram, right, of calls for service to a PSAP, to a 911 center, right? So if you're looking at those overlapping circles, right, there's a bucket of 911 calls, right, that we know, or referrals to a police department or to a PSAP. There's a bucket that we know requires a police response, bank robberies, car accidents, those things. And like Margie showed on that previous slide, and maybe she could actually pull up that slide while we're answering this question, we know there's a bucket that absolutely should just be clinicians, right? Like there is a bucket of, we know there's a bucket of calls coming into a PSAP that police officers are going to that they should not be going to, that social workers and clinicians. But then there's an 80% bucket in the middle where if you can send both, why not send both? Maybe there is a minor safety concern. There is a family disturbance. There's a lot of categories and types of calls coming into a PSAP where a clinician response or a social work response only just is not going to be safe. And most agencies are not going to be willing to send their people out. And that's where you could really use that co-responder model, in my opinion. I would also just add to that, that is something that we hear a lot as part of the national conversation, like where does the work belong, right? And all of those things. We here in Tucson and Pima County, we have a lot of resources. We're far from perfect. We have a long way to go. We have monthly meetings, quarterly meetings of our whole entire crisis system, trying to figure out where the gaps are and where we're falling short. Is there a future where 988 is just omnipresent in the entire country and every single county and every single city in the United States has co-responder teams and crisis mobile teams and all these things? Yes. And we can get police wholesale out of that work. Maybe there is a future where that happens. I don't see it anytime soon. There are buckets of calls that cops are just going to have to go to. And if they have to go, why not provide them with that extra clinical support? But Margie, go ahead. I know you have a lot of thoughts as
and
well.
there's also, so this is, we try to fit those interventions, to try to minimize the police being involved as much as possible. But another thing that sometimes doesn't get recognized is it's not a exact science of figuring out that it's a mental health call. We were doing some research project with the 911 project, and I spent some time plugged in, at communications, and the calls don't come in as obviously mental health a lot of times. They come in as sex welfare or domestic violence or something, and it's not apparent necessarily that it has a mental health component until after people get there. So there's that as well. And then there's always going to be a need for law enforcement, because just as you're going about your patrol business, you stumble in, into situations. And so I think this idea of you could completely get the police out of anything mental health, there's always going to be some kind of law enforcement interaction. And like Jason said, why not give people the tools to do it in a compassionate and safe way, with a way to quickly, as soon as it's identified, pass them off to the mental health system.
Thank you so much for all of that invaluable insight. I know we're coming up right against the hour, so Jeremiah, would you please give us a summary of recommendations for today?
Sure. Wow. This is a packed section today. You know, sometimes we have these presentations that there's a lot of build up and it kind of gets to, you know, a couple points, or when we're doing like a research presentation where there's a lot of kind of front matter we got to talk about, but you all kind of came in strong with like all these different things you'll do and how it works and when it works. And it was great. So I'm going to be not too ambitious here about what to say, because I feel like there was so much covered. First of all, just loving the principle of no wrong door, the collaborative approach, the like, let's just kind of make it work, recognizing that if there isn't a serious criminal issue or a serious safety issue, that basically a lot of situations can be best addressed. Working in a kind of collaborative, creative way with quick referrals and warm handoffs is going to be the most effective for the person, effective for the personnel, cost effective, et cetera. And it was great. Let me look at my notes. I took some notes here. Love the creative example of the towing the car. That, you know, if you see what's needed and you found a way to do it, what the person was really gonna needed as a baseline willingness to participate in the referral. That was very cool. The training piece, Cynthia, I saw your note just there, like a lot the training piece and the fact that you've got a lot of departmental buy-in. I think that's a huge thing. You know, this varies across departments, obviously, nationwide, and some folks see the value and others don't, and need to kind of be dragged along and have it persuaded. I mean, this is something that we see on the SHIELD training initiative often, is that the folks that we're training may just, you know, think that just not understand what different supports are, and how they work and why they work and what it takes for them to work, and then therefore why those can also be allies to the public safety goals of officers. And so helping, the fact that you all have so broadly trained the officers in CIT and mental health first aid, to help kind of build that culture that understands it. And then I think it's really interesting on this time front that basically says, now that through building that culture, we can see we need to take some time to, if we're thinking about de-escalating, we're going to take some time in these encounters. But now that we actually understand how we're doing this, what's going to actually happen is these encounters will be much briefer, and it actually is saving a bunch of time. So it's kind of it's a funny win-win there. So there's a whole lot more that could be discussed. I know there are different folks here who work with different agencies that have different programs, and every community's got their own funny landscapes they've got to navigate. So I appreciate it, and I think we're a couple minutes over time, so I'll stop blathering.
No, you're good. Again, thank you all
Thanks for having us.
Yep, thanks.
Yes. Thank you all for being here. Thank you all for joining today's ECHO session. As a reminder, to earn continuing education credits, please complete a post-session survey using the link in the chat. If you would like to present a case, please email the Be Well Texas team at bewelltexas@utesca.edu. We look forward to seeing you at our next session on Thursday, March 12th. Have a great rest of your day. Thank you so much.